good to see you and Dr. Paul again. This is Matt, the strength and conditioning coach that will take you through the strengthening and return to play phase of your rehab. Paul, would you like to fill Matt in on what happened before surgery and then we can explain the rehab process?
Sure thing. Alex was tackled mid-game while changing direction. Unfortunately for Alex, the sole of his foot remained planted while the knee joint twisted inwards, and Alex described here in a popping sound. I thought that the injury was most likely a tear to one or more of the ligaments within the knee joint, and the MRIs confirmed that he had torn his ACL. The ACL stabilizes the knee joint, connects to the bottom of the thigh bone to the top of the shin bone, preventing it from moving forward. Alex will need surgery to repair the ACL. This is a keyhole surgery which involves 3 small cuts through the layers of the skin.
I met with Alec after his surgery and explained that we would stimulate blood flow by moving his foot up and down at the ankle joint at regular intervals. I also explained that while sitting or lying down, Alec should keep his leg elevated with a pillow underneath the heel and calf, not behind the knee. Alec, are you ready to discuss rehabilitation exercises to prevent further muscle loss? The first few exercises in the initial phase will work on fully straightening and bending your knee, some kneecap mobilization, straight leg raises while lying on your back, some balance work, and then Matt will take you through the next phase.
Hey Alex, so a part of your strengthening program for your knee and the surrounding muscles, we're going to start with targeted exercises, focusing on the quad, so the front 4 muscles of your upper leg, the hamstring, so the 3 muscles at the back of your leg, your glutes just above your hamstrings, and then your calves towards the bottom of your lower leg. I want to start with compounding movements such as deadlifts, lunges, and squats. These exercises will really target those muscles by strengthening and adding stability, whilst also activating your core and abs.
Welcome all. Today we'll be examining the case of Alec, who has injured his right anterior cruciate ligament while playing football. The test that I did for his knee laxity was the pivot shift and the Latchman's test of the knee joint. I identified the need for a reconstruction via surgical graft replacement of the right anterior cruciate ligament. The function of the anterior cruciate ligament provides stability to the knee joint by preventing the femur from sliding posteriorly on the tibia, resulting in hyperextension of the knee. It is at this point in the game where we can see the hyperextension and thus the injury take place. So first I had to identify the landmarks in order to conduct the procedure. The anterior cruciate ligament has its origin at the medial area of the lateral femoral condyle and inserts into the center of the anamnesia of the tibial plateau, anterolateral to the medial tibial meniscus. It ascends posterolaterally to attach superiorly to the posteromedial aspect of the lateral condyle of the femur.
Research shows that in the weeks leading up to the operation, range of motion and effusion reduction of the articulatio genu is advantageous to surgery outcomes. Keeping the supporting structures of the articulatio genu, such as the medial and lateral collateral ligaments, the posterior cruciate ligament and the patellar tendon, as limber as possible is also crucial to surgery outcomes. That being said, blood supply to the anterior cruciate ligament arises from branches of the middle genicular artery which form the vascular synovial envelope around the ligament. These periligamentous vessels penetrate the ligament transversely and anastomose with the longitudinal network of endoligamentous vessels. Vasomotor and proprioceptive innervation of the anterior cruciate ligament comes from the tibial nerve.
In relation to everything that has been mentioned, the exercises I will prescribe to increase his range of motion will consist of stretching and gradually strengthening the gastrocnemius, soleus, and all the posterior thigh muscles, as well as his vastus intermedius, vastus lateralis, rectus femoris, vastus medialis oblique, which is especially important for the stabilizing of his articulatio genu. In the initial phase of his strength program, it will mostly consist of exercises to strengthen the muscles surrounding and supporting of the articulatio genu. Those exercises being standing hamstring curls, partial squats, step-ups and wall slides. These will recruit the gastrocnemius, soleus, semitendinosus, semimembranosus, biceps femoris, as well as his vastus intermedius, vastus lateralis, rectus femoris, and his vastus medialis oblique, and both gluteus medius and maximus muscles. The program will be structured over 3 to 5 weeks, then he will move on to larger compound movements.
So Claire, I know that you said you had sustained some injuries while in the army. Did you want to maybe discuss that?
Yeah, so during my last year of service, I had on and off pain in my lower back, but I had the old soldier on mentality. Then a few months after I discharged, I got to the point where I was in pain every day. So I went to my GP and he sent me off for some scans.
So Claire, how were the scans explained to you?
In the follow-up with the GP, I think he was a little distracted trying to multitask with explaining it to me whilst also filling in the paperwork for DVA. So it was all explained in predominantly anatomical terms.
I know that it would be really important to use that anatomical terminology in paperwork and reports, especially from a military background. Did you have any prior knowledge of anatomical terminology? Or
Yeah, back then I didn't know anything anatomical terms wise. And yeah, he used all these technical terms like, bilateral pars defect, spondylosis, herniated disc, nerve compression, and it was all like another language. And yeah, I left his office fairly confused and didn't really understand what he just said to me.
Hearing the anatomical terms, what type of impact did that have on you? Did you need to do a Dr. Google to understand it?
Yeah, so he had the x-ray there as well, and you could see the jagged broken bit of bone, and you could clearly see that the vertebrae wasn't where it was supposed to be. So between that and all these serious sounding terms that he used, it was kind of scary and concerning for sort of like what impact it would have on myself and my future, because I was still fairly young at the time. But luckily I didn't have to Dr. Google. I had a really good physio at the time, and I sent him a copy of my scans. He called me and explained all the results, put it all in layman's terms, which really helped me to understand it. And that chat with the physio just eased a lot of my concern. And yeah, I ended up finding a new GP when I had to get the next lot of scans done.
I think you really need to be careful about the terms that you use, especially people not knowing anatomical language. I can really confuse them, and they'll need to seek clarification elsewhere, like on Google or with other doctors. Does anybody have another example they want to share?
Yeah, so last year my sister actually fell off a bouldering wall, while rock climbing, and it immediately resulted in her ankle just absolutely blowing up, getting really swollen to the point where she wasn't able to load bear.
That sounds pretty serious. Did she have to go to a physio or to a doctor or something?
Yes, so she went to the doctor the next morning to identify it was actually quite bad. So he gave her referral to go get an MRI. Upon getting the MRI, heading back to the doctor was basically reading from the MRI report verbatim, so using all this anatomical language, stuff she really had no idea about, to the point where it actually started to make her freak out a little bit. She wasn't feeling all that good about the situation as he was talking about everything that was going on.
You really need to be mindful of the choice of terminology for patients and clients, because it has a big impact on someone's understanding. And it's probably a good idea to double check and make sure that they understand what you've said to them before they leave. What did your sister do next?
Yeah, so look, after she left the doctors, she was feeling pretty deflated. So we had a chat. She came in and spoke to me. And I told her to actually go book in with our good friend who's also a physio. Said he'd be able to help out. So she went and booked in with Troy. So after reading the MRI report and taking her through a few functional and movement assessments, what could be done at that current time with the state of her ankle, he was able to let her know in a very easily digestible way what had sort of happened. And then a few of the things on the MRI were most likely picking up old injuries that she just sustained through wear and tear. So once he broke it all down, she was feeling a lot better. She was more confident with what she would be able to do and moving forward. So once he got that report to her, he then sent it through to me, and we were able to start to build a rehab plan. And she was just feeling really good after that. She had a real good sense of direction and was starting to feel a lot more confident.
I guess that's probably one of the biggest things that I've taken away from this whole assignment of going from anatomical to layperson. It's good to understand all the anatomical language and everything like that, but if your patient doesn't actually understand it, they might leave feeling distressed or stressed out that what you've said to them is actually a lot more worse than you think it's going to be.
So I think having a good balance between layman's terms and anatomical terms can help with patients better understanding what's going on in their body. Especially with the knee joint, there's so many structures working together to make it work the way it does. So mentioning that there is the MCL and the LCL also gives them like a better understanding of just how complex it is.
So I wanted to summarize what I've learned from this group assignment, from like the level of responsibilities and interactions between different health professionals, also group collaboration and time management amongst my peers, as well as rote learning, memorizing and repetition.